Chapter 45 Obesity. About 40% of the adults in the United States are obese, with 1 in 10 children becoming obese as early as ages 2 to 5. Obesity rates are at their highest in the South and among lower income and less educated. The processes leading to and sustaining the obese state are complex, with body weight beyond the physical requirements, as well as an abnormal increase and accumulation of fat cells. The increase in number or hyperplasia and size hypertrophy of the adipocytes or fat cells, the large increases in lipid storage, and the pre-adipocytes are triggered to become adipocytes once storage of existing fat cells is exceeded. Primary obesity would be caused by excess caloric intake for the body's metabolic demands, while secondary obesity is a chromosomal or congenital abnormalities, metabolic problems, CNS lesions and disorders, or drugs such as corticosteroids or antipsychotics. There is strong evidence of significant genetic biologic susceptibility factors that are highly influenced by environmental and psychosocial factors. The factors can be considered individually, but in reality they are interrelated. Research has identified several genes linked to obesity, or energy thrifty genes. There's also a strong link between the FTO gene and BMI. People with a certain allele at the FTO gene appear to have an increased appetite, reduced satiety, and higher calorie intake. This research focused on processes that control eating behavior, energy metabolism, and body fat metabolism. Leptin suppresses appetite and increases fat metabolism, while ghrelin regulates appetite by inhibiting leptin, and this is thought to play a part in its compulsive eating. The two major consequences of obesity are due to increases in fat mass and the production of adipokines. These contribute to insulin resistance, dyslipidemia, and hypertension. They may also disrupt immune factors and predispose the patient to certain cancers. Greater access to food with poor nutritional quality. It's also common to underestimate food and caloric intake, along with a lack of physical exercise and low socioeconomic status. Unfortunately, the cheaper foods are often the most unhealthy. People use food for many reasons, as these associations begin in childhood, with a sense of satiety that can be altered. Along with mindless eating, and eating is also a social and often associated with pleasure and fun. Health problems can occur at higher rates among the obese, along with increased mortality, especially with increased visceral fat, and this would go along with a reduced quality of life as well. Most conditions can improve with weight loss. Here on figure 40-5 from our textbook, we just have a diagram showing the negative effects that obesity has on a wide range of areas of the body. Obesity is a significant risk factor for cardiovascular disease and stroke. This risk greatly increases along with the increased LDLs, increased high triglycerides, and decreased HDLs, or the healthy fat. Obesity is also a major risk factor for developing type 2 diabetes. Excess weight makes drug treatment less effective, resulting in hyperinsulinemia, insulin resistance, and glucose intolerance. Obesity also results in GI and liver problems, such as GERD, gallstones, and non-alcoholic steatohepatitis. For respiratory and sleep problems, obesity can also often cause sleep apnea, resulting in snoring and hypoventilation. It also results in reduced chest wall compliance, increased work of breathing, and a decreased total lung capacity. Regarding the musculoskeletal system, obesity can cause osteoarthritis due to the increased stress on weight-bearing joints, especially the knees and hips. Obesity also triggers inflammatory mediators, cartilage deterioration, and a higher incidence of hyperuricemia and gout. Obesity is one of the most important preventable causes of cancer, including cancers of the thyroid, liver, kidney, colorectal, breast, endometrial, and gallbladder, just to name a few. Obesity can also cause many psychosocial problems due to stigmatization, low self-esteem, social isolation, and depression. The first step is to determine if conditions may be causing or contributing to obesity. Be sensitive and non-judgmental. Clarify the reason for questions about the weight, dietary habits, and exercise. When gathering a health history, explore genetic and endocrine factors, along with laboratory tests of the liver and thyroid function, fasting glucose, and a lipid panel. This would be in addition to a height, weight, and waist circumference to obtain an accurate BMI. During the patient assessment, we would assess the body mass index, weight circumference, the waist to hip ratio, and body shape. Assessing obesity is not easy, as every patient is unique, and would be considered obese BMI by that rough algorithm may be perfectly healthy for another person. In the army, they base it purely on the neck circumference and the waist circumference, and often that is not really the best indicator for health. For the body mass index, underweight would be a BMI of less than 18.5. A normal BMI would be 18.5 to 24.9. Overweight, 25 to 29.9. Obese would be a BMI greater than 30, and extremely obese, also called morbidly obese in some texts, would be a BMI greater than or equal to 40. For waist circumference, people with visceral fat with android obesity are at an increased risk for cardiovascular disease and metabolic syndrome. This would be men with a waist greater than 40 inches, or women with a waist greater than 35. The waist to hip ratio is a method of describing distribution of subcutaneous and visceral adipose tissue. A waist measurement / hip measurement, with a WHR of less than 0.8 being optimal. A waist to hip ratio greater than 0.8 places the patient at risk for health complications. Obesity could also be classified by body shape, such as an apple-shaped body with fat located primarily in the abdominal area, or pear-shaped body with fat located primarily in the upper legs. The major effect on obesity has been the changes in the American diet, with a turkey sandwich 40 years ago being only 320 calories, though today that is 820 calories. A bagel 40 years ago was 3 inches in diameter and 140 calories, and today that is 6 inches in diameter, 350 calories. The same can be said for cheeseburgers, soda, and many, many other staples of the American diet. For planning, our overall goals are to modify their eating patterns, have them take part in regular physical activity, achieve and maintain weight loss to a specified level, and minimize or prevent health problems. Obesity is one of the most challenging health problems. Successful weight management can be hard and a lifelong project. The treatment begins with patients understanding their weight history and deciding on a plan that's best for them. An ideal BMI is not necessary and may not be realistic. Modest weight loss of 3% to 5% can have many positive clinical benefits. The greater the weight loss procedures, the greater the benefits, with average weight loss programs resulting in a 10% reduction in body weight. The first step is going to be to explore the patient's motivation, as this is key. A supervised plan of care should be directed towards successful weight loss as well as successful weight control. Unfortunately, there are no magic diets. All diets can work if they achieve a reduced caloric intake compared to their expenditure. This would include fruits and vegetables, bulking to prevent constipation, and sufficient protein. Again, motivation is key. Success depends partly on the amount of weight to be lost. The eating behaviors need examination, and the goals need to be realistic and healthy. A common NCLEX question you'll see about encouraging patients to modify their diet or encouraging patients to exercise is asking what foods they enjoy, asking what exercises they enjoy, because their participation is going to go a long way in determining whether they actually do it. Calorie density is also important, with much or more of a person's diet should be plant-sourced foods and the other one-third from animal protein. One portion of animal protein equals 3 ounces, while one portion of chopped vegetables is 1/2 of a cup. When assessing the patient, ask them questions like, what is your history with weight gain and weight loss? Has there been any dramatic changes? Are other family members overweight? How has your health been affected by your body weight? What do you think contributes to your weight? What does food mean to you? How do you use food? What is your motivation for losing weight? And have you already tried to lose weight? Was it successful? If so, why or why not? Other questions will be, would you like to manage your weight differently? What sort of barriers do you think impede your weight loss efforts? Are there any major stresses that will make it hard to focus on weight control? How much time can you devote to exercise on a daily or weekly basis? And what type of support do you have from family or friends for losing weight? Exercise is an essential part of a weight loss program. It's recommended that it should be at least daily for 30 minutes to an hour. It may diminish the appetite, also reduces the weight to hip ratio, helps maintain weight loss, and also has many positive psychological benefits. Fortunately, there's many assumptions behind the behavior modification for obesity, and that it's a learned disorder caused by overeating. And there are critical differences between an obese person and a person of normal weight is the cues that regulate eating behavior. Other useful basic techniques would be self-monitoring that show what and when foods are eaten, and stimulus control that work to eliminate the cues in the environment that trigger the eating rewards. Encouraging a person to join a support group or other obese persons who are receiving help can go a long way to helping to modify their eating habits. There are many self-help groups available, such as the Take Off the Pound Sensibly or TOPS, and the workplace-based programs. Drug therapy is never used alone and is used only in conjunction with calorie reduction, diet, exercise, and behavior modification. One option would be the appetite suppressing drugs, such as amphetamines, though these do come with a much higher abuse potential and are not recommended or approved by the FDA. Here in Table 40-9 from our textbook, we also have a list of other drugs that have been used to treat obesity. Be sure to explain to your patient that drugs will not cure obesity. The changes in food intake and exercise are essential for sustaining that weight loss, as well as the proper administration, side effects, and appropriate use of those drugs. Bariatric surgery may be another viable option for treating obesity when other options have been ineffective. Currently, the only treatment found to have a successful and lasting impact on sustained weight loss for those with extreme obesity. The criteria for surgery is a BMI over 40 or a BMI over 35 with significant other comorbidities such as hypertension, type 2 diabetes, heart failure, and sleep apnea. The patient must be screened for psychologic, physical, and behavioral conditions that have been associated with poor surgical outcomes. Illnesses known to reduce life expectancy are not likely to be improved by weight reduction. Bariatric surgeries could come in three broad categories: restrictive, malabsorptive, or a combination of restrictive and malabsorptive. In Figure A in the top left, we have adjustable gastric banding, which uses a band to create a gastric pouch. In Figure B in the top right, we have sleeve gastrectomy, which involves creating a sleeve-shaped stomach by removing about 75% of the stomach. In Figure C in the bottom left, we have a biliopancreatic diversion with duodenal switch procedure that creates an anastomosis between the stomach and the intestines. And finally, in Figure D in the bottom right, we have a Roux-en-Y gastric bypass. Adjustable gastric banding limits the stomach size with an inflatable band around the fundus of the stomach. It's connected to a subcutaneous port that can be inflated or deflated to meet the patient's needs as weight is lost. Here's a figure showing that adjustable gastric banding. In a sleeve gastrectomy, 75% of the stomach is removed. This is not reversible. The stomach function is preserved, however. It results in an elimination of hormones produced in the stomach that stimulate hunger. Here we show a diagram showing a sleeve gastrectomy in more detail. And then we have the Roux-en-Y surgical procedure, which is considered the gold standard, as it has a lower complication rates, an excellent patient tolerance, and food bypasses 90% of the stomach, duodenum, and a small segment of the jejunum. Here we have a figure showing in better detail that Roux-en-Y bypass and how it moves food past the stomach. A major complication of Roux-en-Y is dumping syndrome, in which gastric contents empty too rapidly into the small intestine. There should be avoidance of sugary foods is recommended to help prevent this. Other options may be a Maestro rechargeable system. This is a pacemaker-like electrical pulse generator with wire leads and electrodes implanted within the abdomen. They send intermittent electrical pulses to the vagus nerve, which is involved in regulating stomach emptying and signaling feelings of emptiness or fullness to the brain. Here we just have a diagram showing how that Maestro rechargeable system would be implanted around the stomach. For preoperative care, we're going to determine the assisted devices currently in use, as well as their past and current health information. We're also going to need to coordinate their care with both a cardiologist, pulmonologist, gynecologist, gastroenterologist, and any other specialist that may be pertinent. We'll also want to have the room ready for the patient before arrival, including an appropriate sized bed, a larger blood pressure cuff, a larger gown, and any patient transfer equipment that may be necessary. We should also begin the patient with practicing to cough, deep breathe, turning, and positioning, as well as teaching to use that incentive spirometer to go ahead and prevent any issues that may arise post surgery. These patients will require an especially close observation for complications, and they'll transfer with specially trained personnel to stabilize the airway, manage their pain, and keep the head of the bed elevated 35 to 40 degrees. Diligent turning and ambulating will also be especially necessary with these patients, and you may need to coordinate with the other staff members to have assistance. That excess adipose tissue compresses the chest and abdomen and can cause CO2 retention, along with hypoxemia, pulmonary hypertension, and polycythemia. They're also at an increased risk for venous thromboembolism, dehiscence, and delayed healing. This procedure will come with considerable abdominal pain. Make sure to medicate as necessary and assess for any anastomosis leaks. Evaluate the wound condition closely and carefully transition the patient to their new diet. Following bariatric surgery, patients find it challenging to maintain a prescribed diet. The patient now must reduce their intake because of anatomic changes, and attention to nutrition is especially important to prevent early and/or late complications. Long-term follow-up care is important for physical and psychological reasons, as we don't want the patient falling back into old dietary patterns. Ideal candidates have achieved weight reduction as well as excess skin folds or fat that have been taken care of. They may also choose cosmetic surgeries such as lipectomy or liposuction. Here in figure 40-9 from the textbook, we just have an example of the loose skin that can result. The expected outcomes for the patient are long-term weight loss, improvement in obesity-related comorbidities, integration of healthy practices into their lifestyle, monitoring for possible adverse effects, and improving their self-image. Within the elderly, obesity is increasing in prevalence, just like with the rest of society. This also at play is their decreased energy expenditure, which further contributes to increased body fat. It can also worsen age-related problems such as reduced mobility, urinary incontinence, hypoventilation, and sleep apnea. And metabolic syndrome. This is a topic we're going to talk about a lot throughout MedSurg, and we're going to continue talking about. And these are a group of risk factors that increase a person's chances of developing cardiovascular disease, stroke, and diabetes, along with a host of other preventable illnesses. Metabolic syndrome would be classified if three or more of the following occur. A waist circumference greater than or equal to 40 inches in men or greater than or equal to 35 inches in women. They have active treatment for triglycerides greater than 150, HDL cholesterol less than 40 or less than 50 in females, a blood pressure greater than or equal to 130 systolic, or a fasting glucose greater than or equal to 100. Within metabolic syndrome, insulin resistance related to excess visceral fat may occur, as well as an increased prevalence of coronary artery disease related to hypertension, increased risk for clotting, or abnormal cholesterol levels. Lifestyle modifications are first-line interventions to reduce their LDL cholesterol, stop smoking, lower blood pressure, and reduce glucose levels. And finally, you play a major part in the health of your patient, and you can assist with information on healthy diets, exercise, and other positive lifestyle changes. Anyway, that's all I got for this chapter. I'll see you in the next slide.